Okay, because of a technical issue, we will move to the next session. It will be held by Professor Howard Spencer. He's the Professor of Emeritus of Cardiothoracic Surgery at the University of West Indies and Registrar of Medical Council of Jamaica. Okay, so please welcome.
Good morning. I have been asked to present Establishing Cardiac Surgery in Jamaica, the pains, joys, and opportunities. I decided that I would utilize several presentations I've made over the years on the subject of cardiac surgery. And recently, I was asked to present in the British Virgin Islands when it called to quits the ethical dilemma in the management of cardiovascular disease. I tried to fathom what was being asked. Was it when you no longer recognize that you have no resources to perform your cardiac surgery procedures, should you quit? Or when you realize that time has come for you to move on as a cardiothoracic surgeon and allow the youngsters to take over, then you decide which one of those options you are going to take in relation to when you quit. I thought that if you don't know your history, as the slide says, you don't know what you're talking about. And therefore, when I set on making this presentation, I thought that I would discuss what I did as a cardiothoracic surgeon, where you managed cardiac surgery and general thoracic. I understand from my colleagues in the United States, you're either a cardiac surgeon or the general thoracic surgeon, and the two may never mix. So I thought I would give a little bit of information from my years as a cardiothoracic surgeon, and this it introduces one of the cases I was faced with, where there was an aneurysm eroding the ray through the neck, and it only being kept intact by skin of the neck. And also, we handle trauma, and you can imagine what you may have to do in relation to this case of traumatic in which the machete was introduced into the chest. Of course, the patient was alive and was able to arrive to have a procedure done. Dr. Corey was one of the earliest cardiothoracic surgeons in Jamaica. He did many procedures at the National Chest Hospital, which was formerly the tuberculosis hospital. He did thoracoplasties, drainage of empyemas, drainage of pneumothorax. And he was the only cardiothoracic surgeon in Jamaica for many years. Here we have, to the right, Michael Wooming, one of the greatest teachers. Here he is demonstrating the heart to these youngsters. And Michael Wooming was the father of cardiothoracic surgery, or cardiac surgery in Jamaica. And on the left, you see Siva Pragazan. He was the father of cardiac surgery anesthesia. And those were the two persons that were my mentors for years in my learning the process of cardiothoracic surgery. And this is the first open heart surgery which was performed by Michael Wooming and the team in 1968. Now, when we look at the early surgical management of heart disease, the trends in surgical management of cardiovascular disease involve the identification of the place of palliative surgery in congenital disease compared with early correction of the defect. In the case of acquired disease, the choice of repair compared with the replacement of the valve was also very important in our setting. For replacement, the choice of valve utilized was also critical, since the age of the patient influenced our choice. The young patient, you put a mechanical valve in that patient, you have to anticoagulate that patient. And these patients, you can imagine trying to get a 60-year-old or an 80-year-old kept on anticoagulation and the dangers that one faces with the activity of that young person. Now, the choice of valve for replacement was also influenced by the lifespan of the valve, as I said, compared with the patient's lifespan. If you implanted it early in life, the child had many years to live with this valve, and would this valve have to be changed several occasions? Replacement of the failed valve is associated with increasing morbidity and mortality as the number of reoperations increase. Now, when we looked at pediatric cardiac surgery, palliation to treat emergencies which may occur with complex disease, or if the child was a neonate or very young, would enter into our decision as to what to do. Open heart surgery to correct lesions was utilized either to correct the lesions or a staged correction. And here you see tetralogy of Fallot, the blue baby, a number of children presenting to us with critical cyanosis, and we had to make a decision as to what to do in relation to managing these patients. And as you see, there are the palliative shunts. There are a number of different shunts that one can do. And whenever you see a number of different procedures that you can do as a surgeon, then you know there is no right procedure. And here you see the blue child squatting to increase the flow of blood because of increased hypertension in the lower areas. And here are two personalities. You always have to reflect on who were there to help along with the process of managing your patients. And to the left there is Dr. Leela Winter-Wedderburn, who was the first SMO of our Bustamante Children's Hospital. And there's Dr. Mackenzie, who managed a number of the patients with pediatric cardiology. And here you see Magda Yacoub, Sir Magda Yacoub, with one of the patients operated on. And there is the little child smiling, and the procedure having been done. And here we have Dr. Perriman. Dr. Perriman, we had a number of visiting teams over the years, and Dr. Perriman was one of the surgeons who visited for DiMaggio Children's Hospital. And this was one of the early surgeons done on visit by Dr. Perriman from DiMaggio. And this was our first pediatric open heart surgery at the Bustamante Children's Hospital. Now, in the adult and adolescent, cardiac surgery procedures, they may be either the closed heart procedure, in which cardiopulmonary bypass was not used, or the open heart, where cardiopulmonary bypass is required, and you may have an off-pump procedure or an on-pump procedure. And there we have the mitral stenosis being corrected by the introduction of the instrument through the apex of the heart, through the valve, and then when you depress the handles of the valve was split, and you produced a functional valve. Of course, you had to ensure that you did not change mitral stenosis for mitral incompetence. So we did a lot of these procedures because from the point of view of, one, correcting the problem, 2, not having the open heart surgery equipment to undertake the procedure in those days, then this was a common procedure we did. And quite a number of patients survived many years after. And a few came to have reoperation, open heart surgery, replacement of those valves. And as you know, there are a number of valves that you can have. You have ball valves, like the hinge valves. So there were a number of valves available, and the choice of valve was critical in those days, as I said, depending on who you had planned to put that valve in. And of course, we also undertook the procedure of using the aortic valve from a cadaver. The aortic valve was dissected. This is a valve being dissected, and it was, after being stored in antibiotic nutrient solution, the valve was placed in the mitral position in a top half of Dacron to support it. And you also could replace the aortic valve with outer support of Dacron. These procedures were introduced to us by Sir Magda Yaqub, and again, it bought time for a number of our patients who required surgery and in a limited resources environment. And of course, as you see, there are a number of complications that one may have after replacing with the mechanical valves. There's the ball of the Star Edwards valve in the junction of the aorta. Of course, you're able to produce this because this was a postmortem specimen because of the disaster that was created by the valve being released from its cage and being trapped in the bifurcation of the aorta. And here is a tissue valve and a paravalvular leak, again a disastrous problem that may result and you had to do replacement of the valve if the patient was able to survive such a disastrous problem. And here you have valves years after they became calcified. This is a tissue valve. And of course, we discovered that the tissue valve in a young patient calcified much more rapidly in the older patient. And again, it presented us with a problem because a number of our patients were young and required the procedure. And here you see the myriad amount of equipment that one requires when you are going to perform open heart surgery. And here I begin to introduce what were the challenges in relation to the cost of all of this material. And as this cartoon says, it's expensive care. That's what the painter thought that it should be on the intensive care. So it was being corrected by, of course, the stern sister in charge. And of course, pacemakers were very expensive, and this cartoon suggests that you may have to hold up someone to get your pacemaker. Now, this was done by a youngster who painted for us, and what we were trying to show here is the cost of the heart valves in relation to the primary products that we produced in those days. Bananas, we shipped bananas overseas. Sugarcane, of course, producing the problems with diabetes and so on. But sugarcane was a product that the First World desired in large amounts, of course. That was part of the slave trade. We also had bauxite, and this reflects the cost of the valve in relation to the products that we exported. We needed sometimes the cost of 11 tons of bananas, 10 tons of cane, sugar cane, providing the sugar, 55 tons of bauxite, which was a mineral, which was the precursor of aluminum. And it demonstrates that we were trying to meet the cost of an expensive procedure with the primary products that we exported. In the case of the investigation of the patient, those of you who know the history of cardiac surgery recognize in the early days that cardiac surgery procedures were performed on the basis of the cardiologist listening to the murmur and say, oh, yes, that is mitral stenosis. Or yes, that is an atrial septal defect. And let us go in and correct it. And the only way you could correct it was that the patient was hypothermic, then having reduced the temperature of the patient to about 30 degrees centigrade. Then you had your team ready because you had to perform that operation, that is open the chest, stop the heart, repair the defect in about 15 minutes. And of course, if when you opened the heart, the diagnosis was wrong, you had to abandon the procedure. Those were the days of operating without the correct material to investigate. I didn't perform those operations. I was too young in those days. But this shows you the investigative material, the facility that we required. And there it is, $1 million US, we were required to spend to have this sort of facility. And of course, this shows that did we have to spin a coin to arrive at what to do when we had a patient on the table? Or because of the get-up that we used to have on in those days, you had to be masked, you had to be gowned from head to foot, you could not go into the operating room without getting a bath, and then entering the operating room with a get-up. And here he is saying, with this get-up, any lunatic off the street could sneak in here and pretend to be a surgeon. This is one of the foundations that I created, and this foundation was created to provide the material that was necessary: valves, open heart equipment, and so on, for the procedures that we did at the University Hospital. But we also, this foundation also helped with the collection of donations from our friends in the cardiac surgery units, because at some point in time we had significant difficulty in obtaining the material that was necessary for open heart surgery. We also established a Caribbean Cardiac Society, in which we brought together the cardiac surgeons and cardiologists in the Caribbean in this society, where we could share our experience and we could also share the materials for surgery. This society still exists today and will next year celebrate its 30th anniversary. And we're going to have a big meeting here in Jamaica, and you're all invited to attend. Now, we also suffered in a way from the fact that despite the fact that we were doing cardiac surgery since 1968, this was a newspaper publication in 1990, 2001, 2005, open heart surgery here for the first time, despite the fact we were. And so we are always faced with the publicity that we were not doing open heart surgery. It may be because the population felt that we couldn't do open heart surgery. So therefore, when we had our friends who came to help us with the procedure, it was open heart surgery being done here for the first time. And of course, this is our reaction sometimes to the fact that nothing good locally can be used. It always has to be imported stuff. And this cartoon, and by the youngster who painted the previous one, shows that for us to get the treatment that was available in the first world, to cross that bridge or chasm, you needed thousands of US dollars to get across there to have your procedures done. So this was why it was important and critical for us to be able to do these procedures here in Jamaica. And also to do procedures which were difficult and very specialized right here in Jamaica. Now, as a cardiology in developing countries, again to emphasize that rheumatic fever and its late sequelae, rheumatic heart disease, where you get stenosis of your valve, regurgitation of your valve, were and are still problems in our countries as developing countries, and still require cardiac surgery for the treatment of this complication, which is mitral stenosis, mitral incompetence, aortic incompetence, aortic stenosis, and so on. And cardiovascular diseases, which includes ischemic heart disease, is approaching epidemic proportions in developing countries. And now it probably is the leading cause of death, because cardiac disease is the leading cause of death in our country. This too needs cardiac surgery, that is coronary artery disease, needs treatment in many cases in our country. So therefore, in establishing cardiac surgery in Jamaica, what are the pains, what are the joys, and what are the opportunities? The pain is still to see a young patient with rheumatic valve disease without the facility to treat this patient in time before they reach the stage of chronic cardiac disease, chronic heart disease. Impossible to do anything surgical at that stage. And we need to see these patients early enough and manage them so that they don't go into this situation. It used to occur some time ago because we are better managing these patients in our setting. What are the joys? When we look at surgery we are able to do now, and the surgery we are able to do on our pediatric patients with the help of our visiting doctors, our friends, and so on, it is a joy to see the children after their cardiac surgery, a number of years after their cardiac surgery, with the pleased parents and the pleased, joyful children. Those are the joys that one gets with what you have to do in cardiac surgery in Jamaica. Now, what are the opportunities? Cardiac surgery, future in Jamaica, we need to be self-sufficient. We cannot and should not continue to rely only on overseas teams. Between 1994 and 2011, 7 visiting teams made 41 visits to Jamaica. And the main contributing teams were from the Caribbean Heart Menders, the Jamaica Children Heart Fund, and very importantly, the UK-based Chain of Hope, which was with the help and which was managed by Professor Sir Yabdi Makoub, and this team continues to help with the cardiac surgery at the Bustamante Hospital for Children, where in 2010 a memorandum of understanding was signed between the Minister of Health, the Southeast Regional Health Authority, and the Chain of Hope, and other stakeholders to undertake the building of a self-sustained pediatric cardiac center at the Bustamante Hospital for Children, to assist with the training of staff and procurement of equipment for the new unit. So you see that the pediatric cardiac patients are being taken care of by the building of this unit. We now have a very skillful young surgeon, Jamaican, and teams still visit to assist with the cardiac surgery procedures there. But this young surgeon is doing more and more. But we still need also the material that is provided by the visiting teams. As I said, the cardiac center was completed. It was opened last year at the Bustamante Hospital. Consisted of an operating suite, cardiac catheterization laboratory, and a 10-bed intensive care replaced the existing 5-bed unit. Because it's always a challenge to find intensive care beds in Jamaica, because it's not only required by people requiring heart surgery, it's required by people with severe trauma, and so on. And so whenever we can improve the intensive care bed setting, then that's a step forward. But what is required? We have the expertise, and part of that expertise is, of course, Dr. Madhu's Heart Hospital. We have heart surgery procedures being done also in the University Hospital of the West Indies, where heart surgery originated in Jamaica. So we have the expertise, we have the cardiac surgery units. What is missing is a will to cooperate, to provide service to all, rich and poor. We must not only decide to provide service for the rich, we have to provide service for the poor. And that requires the desire to help the poor, not the rich, because you may not have anything to gain because you have looked after the poor patient. But that is what is required. We need to cooperate, and we need to provide service to all, rich and poor. Thank you for this opportunity.
Okay, so next will be a presentation by my senior colleague, Dr. Gustavo Knopp. He's the Director of Cardiovascular Surgery and consultant of a consultant cardiovascular surgeon at the Heart Institute of Caribbean. So please welcome Dr. Knopp.
Good morning, everyone. Okay. Presentation. Here. Green. Well, the title is not here. I went directly to the first. Okay. The title mainly is directed to what is the future about cardiac surgery in general and in Jamaica in particular. So I have to recognize that the brave men were Dr. Spencer, because in those days they have to do things with great courage. Now this is for anyone. This is what happened in the 70s and the 80s. The king was the cardiac surgeon. Cardiologists, to the right side, the cath lab coming for desperate, oh, I have a complication with the angioplasty, the patient is dying in cardiogenic shock, and the cardiac surgeon had to go and sort the situation. Things changed dramatically on behalf of them, not on us. So, well, a brief history of cardiac surgery has been already explained by Dr. Spencer. Basically, in the 50s, the cardiopulmonary bypass was possible, and after that there was a huge advance in procedures done over on cardiac surgery, but it was at the discovery or the use of the cardioplegia that made a big advance. Cardioplegia is a solution that is infused in the aortic root to put the heart to sleep. And why this is very important? This is very important because you can do the job with a still heart. That's number one. And secondly, the oxygen consumption of the heart is almost based on the mechanical action. If you put the heart asleep, the heart still consumes oxygen, but at a very low levels. That is why you can have a well-preserved heart with good cardioplegia infusion in different techniques or whatever for quite a long time, relatively safely. And the curves of complications starts to increase after quite a time. So, regarding ischemic heart disease, there has been an advance in the medical treatment. Medical treatment has had a huge advance in the last 30 years. So the territory for intervention had in some way, although the risk factors increased and will become even more with the obesity, hypertension, and all these kind of epidemics in the world. But despite that, medical treatment has given a good help on the treatment of ischemic heart disease. Then, regarding the acute events like acute myocardial infarct, cardiac surgery has a very, very limited field on treating there. Basically, obviously, the PCI is fundamental in the treatment of these acute events. Only in very selected cases, with a patient in cardiogenic shock, with bad targets, impossible to go ahead with the PCI or very risky because of high scores of calcification and so on. In those very selective cases, unfortunately, the surgeon has to act in cases with high risk, probably with balloon pump, cardiogenic shock, but that is the only option. Regarding the complications of the myocardial infarct, in that field, the surgeons had some action, of course, to do. But even then, in the future, and going to the core of this presentation, most probably the future will bring some percutaneous solutions for even those complications. Meaning, for example, VSD post-infarct. I'm not sure about, obviously, when you have a papillary muscle rupture, there is no way you have to go to surgery in a very complicated patient, and acute rupture of the LV is a situation that rarely you have the chance to face because most of the patients die before getting the hospital. Regarding the treatment of the coronary artery disease in patients with chronic stable angina, unstable angina, that is a field of continuous debate. No patient is the same than the other. It doesn't matter the map you find in the coronaries. No patient is the same than the other. There is it's not appropriate to take decisions only based on a simple mapping. Okay, I have left main, I have proximal LAD. Obviously, this kind of reasoning helps a lot, but we have to take the patient in context, and decision-making must be based on the facts that has been demonstrated mainly in the last 10 to 15 years, even recently. So there are quite a number of randomized clinical trials that demonstrate which patient is more, can benefit more from one procedure or another procedure like, PCI or surgery. And these kind of efforts still continue to evolve. There has been a talk from the head of Cleveland Clinic, the surgeon, not many years ago, about 4 or 5 years ago, that even with these trials had impacted and demonstrated which are the best options for patients, he confessed that in US, this is not fulfilled. There is a big competition about financial issues that can impact on the decision making. On the opposite, in some other parts of the world, for example, UK, the risk aversion of the surgeons to to deal with complicated patients and sometimes the Euroscore or other kind of scores you can use demonstrate a number that possibly do not reflect reality. And you see the patient and say, oh, risk aversion in UK is a big issue. It is happening the opposite. Surgeons try to get rid of the high-risk patients and give to the cardiologist. The cardiologists are doing more risky patients, not because they have the indications to be done, because the surgeons reject those cases to be done. And it is very common to see in the meetings with all the people there, clinicians, interventional cardiologists and surgeons, to see decisions that are not according to what these kind of trials demonstrate. So this is basically, which is at the moment, the best approach, which favors PCI and which favors CABG. Going to CABG, you can see from the clinical point of view, the more risky is the patient, the more deteriorated is the LV function, the more vessels are involved, the more proximal compromised left main proximal LAD, the best are the outcomes of the patients with surgery, although you have to pay the bill for a higher risk or more mortality and morbidity. Diabetes is a risk factor that favors surgery, especially insulin-dependent and long-standing. Reduced ejection fraction, as I mentioned. The lower the ejection fraction with more viable, hibernated or standing myocardium to be recovered, the more can benefit with surgery. Then you can have patients with some contraindications for dual antiplatelet drugs, which are mandatory for stents, acute thrombosis. In those cases, although the anatomy may favor PCI, it should be better to do surgery, gastrointestinal bleeding, past history of bleeding in the brain and so on. And you can have cases which have previous stents, repeated stents, stent over stent, and then what you do with that patient? Continue with the stenting? Well, there are cases that you have to go to surgery. And there are some cases that has been so many stents on the LAD that surgeons don't have any place to put the mammary. So that is a disgrace, but you have to go to the apex sometimes and get a little bit of 1 millimeter LAD and put the mammary there and try to get a long mammary, a non-pedicle mammary, and try to get there. It's unusual, but not impossible to find a case like this. And then you have the anatomical and technical aspects based on the syntax score that has been already demonstrated, and we had a listen in this Congress about that. The higher the syntax score means that the results with PCI are worse, and the repeat revascularization procedures are higher. So that favors surgery to be done as a first procedure. Obviously, if you need to do a concomitant operation on the aortic valve or the mitral or the ascending aorta, there is no point to do PCI and then do the other procedure. You do the whole thing at the same time. On the side of favoring PCI, we have already spoken about that. Even in triple vessel disease with a low syntax score, there are no great benefits in survival, and only, obviously, it's demonstrated that you need more repetition of procedures, but it's clearly determined that there are no benefits in the way of survival benefit. Left main disease is a little bit of a debate depending on the place, if it is a shaft, if it is a ostial or bifurcation. So any case has to be discussed. A great advantage in CABG has been the use of both mammaries, pedicled. This is not an operation for anyone. It's a very meticulous operation, has to be done for very well-trained people. It has more risk in the terms of infection. It is a bit of a challenge to do in diabetics because of devascularization of the sternum and the higher risk of mediastinitis, infection of the sternum and the mediastinum, which is a very serious complication of surgery with high mortality. But there is no doubt that two mammaries, long time ago, Cleveland Clinic presented a paper in the 90s. Two mammaries are better than one. And there is no question that mammaries are better than the vein. Veins are acceptable on the LAD territory. The patency rate is about 80% at 5 years. Mammary is more than 95%. But on other territories, the patency rate decreased significantly, 50–55% at 5 years. So the best option is to use two mammaries, but has to be done in selected cases by people who are used to do it and because you need several skip grafts and reach the right territory as well. This is the way it is done with a T. I mean, the right mammary is disconnected, and then anastomose to the left. So the left provides everything. Any minimal technical problem in any anastomosis, you lose the patient. As simple as that. In the 90s, there was a fashion to try to do, surgeons try to fight with, minimal access surgery. And a small incision in the fourth space, you can do a Lima to LAD, left internal mammary artery to LAD. You can do also to a diagonal as well, but it starts to complicate a bit more because if you use a venous graft, you have to connect it to the aorta, or you have to skip. It is an operation that it is doable. Really, it is advertised that less pain, less bleeding, possibly less bleeding, but pain, I don't think so. Most of the time you have a fracture of the rib, or if not, pain is similar, even more. Sternotomy is not so painful. So, but it is one option, and very, very attractive. In a little incision, you have a cardiac operation. Obviously, it has to be done off bypass. You cannot go on bypass. On a beating heart, in a little space, in a depth, you have to do that. It's challenging. Okay. So, in three vessel disease, we have also made comments about which are the discrepancy of what to do in these cases, what is favoring one procedure and what is favoring the other one. And there are some hybrid procedures that some people do, trying to optimize and say, okay, I do percutaneously two vessels and then off pump another one. Well, I think everything is okay. It's very nice to talk about this, but on practical reasons, you have to go for the safest procedure for the patient and the more effective way in the long term. So people sometimes are a bit anxious to show things to be done. This can be done, but has to be safe and equivalent to the usual procedure. There is no debate that off-pump surgery has a place in coronary artery revascularization. Some people are in favor of that. There is some trends showing that there is less bleeding. Off pump, you don't need to use, obviously, the Harlan machine. There are less impact on the platelets dysfunction and many other things, cytokines and so on. There is also less heparin that you use, half dose of that. But there were, I don't know really, I can't tell here, but if there were really serious follow-ups of angiographies in big numbers, what happened with these people with off-pump, which I don't criticize that. Some people do it very well. I have done quite a good number of off-pump as well, but I have to admit that it's not the same. It doesn't give you comfortability. You suffer like hell sometimes on the circumflex side mainly. LAD, okay. This kind of devices you see there has made things much more comfortable. The heart is beating 70, 80. It looks impossible, you can't do anything, but when you put those things there that stabilize, you have a little segment of 3 centimeters, which is okay. You have to concentrate on there and ignore the other things. It's like being operating in a heart still, because that small area is okay, is still. Obviously, there is a risk of ischemia, a risk of deterioration of the cardiac function during the procedure. Anesthesia is crucial in this kind of operations. The anesthetist has to be, hand-to-hand working, use of NORA, positioning of the heart, the dialogue between the surgeon. But in summary, it can be done. There is a trend of less total revascularization with off-pump. Many times you see a difficult vessel, this vessel is not so good enough. It is okay. The reason is it's difficult to do it and you decide not to do it. But, so being honest, you can go easily. You can go to the LAD territory, you can go to the PD. Do the right is a bit risky off pump with this, because the right goes, if you delay a little bit more, you have block, AV block, and that goes in low cardiac output immediately. I see more risky the main right, so PDA is safer. So you have that small thing that you can lift the heart. There are many techniques. 1 minute. Okay, thank you very much. So basically, going to the valvular heart disease, the big advance has been the TAVI. And surgeons can collaborate with the interventional cardiologist, and they do it together. And it's a field that is coming soon. These 3 types of access is through the femoral, through a small sternotomy. You can go directly in the ascending, or you can go through the apex with a little incision in the 4th or 5th intercostal. So the future of initially was used in high-risk patients with no possibility for surgery, but now there are trials in lower-risk patients and even in younger patients. I have to admit, I think, going to the core of this presentation, the future for aortic valve will be this, and surgery will disappear on simple AVR. I think that. Well, there has been many advances, and they are reducing all the complications, and the transapical is not a barrier for peripheral vascular disease. So this is more or less the same I have been talking about. A couple of words about mitral. Mitral, in the old days, Alfieri technique doing in surgery was a bad word. When you don't know how to repair a valve, you put a stitch, and I said, I did an Alfieri. Alfieri is a stitch in the joining anterior and posterior and converting the regurg in 2. So in that way, you decrease the regurg. That was a sin in the old days. And suddenly, after that, it became a great procedure. So, I mean, It's because you can do something for those cases with dilated myocardiopathy, ischemic or necrotic, where mitral valve, chronic mitral valve incompetence is a big issue and will impact severely on the survival of the patient, and you can help doing that. The Alfieri, which is the mitral clip, which is becoming very common nowadays. So we have spoken about that. Well, mitral valve, degenerative chronic mitral valve incompetence still is the territory of the surgeons. It will evolve percutaneously, but so far the best repairs has to be done in surgery and has been demonstrated very good results. It has to be done early before you have any deterioration of in good hands, of course, when the mortality is low. It favors surgery very early before the ejection fraction goes below 55. We have spoken about this. Well, some future for pulmonic valves is a reality, tricuspid as well, but pulmonic valve is a field for percutaneous action. And there will be some, obviously in the future, some advance in the bioprosthetic materials and to use it in younger age. For sure, that will evolve and become more common. Regarding this, one word about the TAVI and so on. USA has found the solution, as usual. They find the solution for everything. To avoid the competition, which is money, they said, okay, we pay to the surgeon as well, the same as the interventional cardiologist. In that way, the surgeons are okay. You want to do it? That's fine. I get the same money, so that's okay for me. Well, no time. Aortic surgery still is the territory of surgeons. No way ascending aorta. When the ascending aorta is dilated, when you reach more than 5 centimeters or 5.5, you have to go to surgery because the curve of complications, which is like this till 5.5, goes like this after reaching 6. So you have to go. And there is another calculation not based on the centimeters of the ascending. It's not the same, my aorta, compared to the big Jamaicans like that. I mean, in myself, if I have an aneurysm of 5, I have to think carefully of going on. The guy with the 2.5 meters, probably 5.5, he can go, no problem. So there is a calculation, it's a mathematical calculation, more than 10, I don't know what, I can't remember, it's geometry. Well, there is a field for cardiac transplantation, but I have no time for that. Sorry about that.
Thank you very much. Thank you, Dr. Knopp. Very interesting, the difference between cardiology and cardiothoracic surgery. I'm going to be asking that we take a 10-minute break. I'll be holding all questions for this session and combine it with the session 8 because in the interest of time, we're a little bit behind. So can we please take a 10-minute break, stretch, have coffee, and then come back exactly 10 minutes for session 8. Thank you.